All right, today we have another episode from the archives with one of my incredible guests. Enjoy. Welcome to the Trauma Therapist Podcast, a show about the incredible people dedicated to helping those who have experienced trauma. My name is Guy McPherson, and my mission is to raise the awareness of trauma and to inspire each of us to help those around us. All right, guys, welcome back to the Trauma Therapist Podcast. My name is Guy McPherson. Today, really excited to introduce my guest, Ruth Lanius. Ruth, are you ready to go?
Yes, I'm ready to go.
All right.
Thanks for having me, Guy.
You are so welcome. Ruth is a professor of psychiatry and the director of the Post-Traumatic Stress Disorder Research Unit at the University of Western Ontario. She established the Traumatic Stress Service and the Traumatic Stress Service Workplace Program, both services that specialize in the treatment and research of post-traumatic stress disorder and related comorbid disorders. Ruth's research interests focus on studying the neurobiology of PTSD and treatment outcome research examining various pharmacological and psychotherapeutic methods. Ruth regularly lectures on the topic of PTSD nationally and internationally. She has recently published a book titled Healing the Traumatized Self, Consciousness, Neuroscience, Treatment with Paul Fruin. I'm holding that book in my hand here. It is a tour de force, definitely. But Ruth, again, thank you so much for taking the time to do this. So let's kind of get in here and first kind of give us a little context. Tell our listeners where you're calling from and maybe where you're from, and then let's get going.
Yeah, so I'm calling from London, Ontario, which is located in the middle between Toronto and Detroit, so in southwestern Ontario from Canada.
And is that where you're from?
No, I was actually originally born in Germany, and my family moved to Canada when I was 13.
Wow. Okay. So nice. So let's start out here. At the Trauma Therapist Podcast here, this really is to put the highlight on you. And we start out with either a quote, a mantra, something to give our listeners an understanding of what's inspired and kind of guided you and the work you're doing.
I think a mantra that has really inspired me and sort of kept me going has been never lose hope. There's always light at the end of the tunnel. And I think that's really important if you're a trauma therapist, but I think it's equally important if you're a client. And so I think it sort of keeps that patient or client therapist dyad really going in times when it can get very difficult and when a lot of suffering can come up. I think that's really something that's guided me both in my professional but also in my personal life.
So if we were to maybe dial in and look at how that's impacted you professionally or how that quote began to resonate with you, can you share a story of when that, obviously, we talk a lot about the word hope in this particular specialization, but for you, when did that become resonant for you, Ruth?
I think very early on when I started working with traumatized individuals, and I'm thinking of a particular one that actually I met during my residency, and, she had spent about 8 years as a psychiatric inpatient. She'd had a terrible journey and she'd really lost hope. And so intuitively, when I first saw her, I thought, wow, she's such a competent woman, even though she's so ill. I sort of saw how I imagined her after good treatment. And, I said to her, I realize you've been incredibly sick, but, I see all these strengths. And so I think there's a lot of hope here. And I think that hope really helps us to have light at the end of the tunnel. And she told me later that it was this hope that had really helped her keep going during very, very difficult times because, during treatment, she, had relapses. Her, obviously her symptoms didn't disappear all of a sudden. It was a lot of very, very difficult work. But, she said, she could hold on to that hope and really follow that light at the end of the tunnel. And she said, sometimes when she could no longer see the light at the end of the tunnel, she knew that I was holding up the light for her. Wow. And so what that taught me was, it's so key to really provide somebody with hope and, guidance throughout the difficult path of treatment, and, provide light at the end of the tunnel. And if the person loses sight of it, then you hold up the light for them.
So you were a resident at the time.
Yes, I was.
A relatively, newer clinician. Did you yourself have hope?
Yes. When I saw her, I thought, wow, I think she's really treatable. And she'd had a number of diagnoses that, didn't quite make sense to me. And I interviewed her, and it really seemed that the trauma she'd experienced, which was horrendous, seemed to be at the root of all these vastly different symptoms she'd been experiencing.
Mm. Awesome story. So as we move on here, Ruth, we get to the question of how you got into this field. I mean, you've been doing this for a while. You're, speaking both nationally and internationally. People get into this field and the specialization of trauma, obviously for many different reasons. I've often talked about one of my inspirations, which was my brother who came back from Iraq with PTSD, and how I just pestered him to talk about his experiences, and I blew it. But share with our listeners and take us there. Share a story. How did you get into this field?
Well, it's actually funny because I had originally signed up for neuropathology, so working with brains after people had died. And I think that came from my research in neuroscience. I had done a combined MD PhD program in neuroscience. And so I thought, maybe neuropathology would be a good way to continue my interest in neuroscience. And then I started my internship at the University of Western Ontario here in London, Ontario. And my first elective was psychiatry. And I worked on a very nice inpatient unit that actually had a lot of trauma patients. They weren't labeled as such, but they had experienced a lot of trauma. They were there because they were very dysregulated, suicidal, didn't really have a sense of self. And so I was exposed to a lot of clients with that history. And I remember, spending a lot of time with them, listening to their stories, and really trying to figure out how the mind had adapted to their horrendous experience. And I think that's when I really started being very interested in trauma, because I realized how much you could do for somebody like that, working with somebody like that, how you could help them to, change their sense of self, or even have a rebirth of the sense of self if somebody has never had a sense of self because of the experiences they've had. And, I realized how difficult it can sometimes be, but I thought, compared to other disorders, if you hang in there, like we talked about, if you, keep having that hope and keep having that light at the end of the tunnel, you can get somewhere and you can really change someone's life. And I think that's something that really, really inspired me.
I love that phrase and the idea of a rebirth of a sense of self. Can you share with our listeners when that became an idea for you, or was it an individual that you worked with that you said, "Wait a minute here, maybe there's something to this idea"?
Yeah, it's actually, I think it came about working with a number of individuals, and I keep asking them, tell me about yourself, tell me about who you feel that you are. And so often people say, I really have no idea who I am. And so I realized, wow, it's really the sense of self that is so much affected by trauma. And that's something we really have to either change or sometimes build up from scratch if somebody really has had a tremendous history of neglect and abuse. And so over time, we began thinking about that more and more. And in addition to clinical work, I also do a lot of research doing brain imaging, really seeing what brain areas are affected by early life trauma. And we were starting to do brain scans, so looking at brain activity at rest. And the network that's really active at rest, which is called the default mode network, we hypothesized may really reflect the sense of self. And so we compared that in individuals with a chronic early life trauma history to healthy controls. And we really found that this network was profoundly disrupted. You don't have to know anything about neuroscience or neuroimaging research. If you compare the two pictures, which I can share with you, you really see a profound impact on that network. And so we speculated on whether that may be one model of the sense of self. And the brain regions that are involved in this network really involve, brain regions involved in knowing what you feel, in regulating your emotions, on integrating past memories and looking into the future, which are key elements of, a functioning sense of self.
I think that gives a clinician and someone is sitting with someone who's been traumatized, it really provides them such a grounding or a mooring, if you will, from which to work. I mean, as you described, invite a client or a patient to talk about who they are and to discover and hear them say, well, or to even just express, I don't know who I am. I mean, I think that really gives us as clinicians a key from which to work, from where to begin working. And it's
absolutely.
That's so rich. I really love that, rather than just, talking about symptoms. And not to say that people are all doing that, but it just kind of really brings into the whole question here, the existential component, if you will, and how important that is impacted by trauma.
Absolutely. I think any treatment we engage in, we are working on that sense of self, right?
Yeah, I love that. And was that something that really inspired your research? When did this how did the research component come into it for you, related to trauma?
Actually, very early on during my residency already, my mentor, Peter Williamson, allowed me to do brain scans of people who had been traumatized. And so we got into the neuroimaging very early on when it first started. And so it allowed us really to make that invisible injury, which psychological trauma is and psychiatric disorders were at the time, right? It allowed us to make that invisible injury more visible. And that was incredibly validating for people as well, right? Because so often traumatized people get told, there's nothing wrong with you, get over it. And so when they were able to see that their brains were actually activating differently from people who hadn't experienced trauma and who didn't have post-traumatic stress disorder and related disorders, it was incredibly validating. And then we always talked about, the goal of therapy is to reach, levels of brain activation that are similar to people who don't have these disorders. And again, I think it gave people hope and it gave people validation, and people felt less abnormal, right? As you know, when people first come in with PTSD and related disorders, they think they're the only ones experiencing these horrendous symptoms. They feel so alone. And so validating that for them, that was a big shift.
I love that. Ruth, share with our listeners an early clinical error. Obviously you've been doing this a long time. You kind of referenced a point when you were doing your residency, but take us back and tell us a story about one of the kind of, errors you've made and how that impacted you.
Yeah, I think it was a very important learning experience, and I think it repeated itself throughout my early clients that I was seeing. And I think when you're treating traumatized individuals, the suffering is so great, and you see the distress people are in. I think you feel that, you want to move in there and you want to change things. And I think sometimes you move in too much and you think you actually have more power than you do. And over time, I realized, my clients are incredibly resilient. They've experienced things I could probably never have survived. They've got tremendous strengths. I think I need to sit back more. I'm a coach. They have all the strengths. They can get through this. What they need is a coach. And it was that shift where I was able to be more relaxed because I think I was having more skills, and they were coming on board. When I was able to sit back more and just believe that they can do it, believe in my clients, and have less of this urge of having to move in and, help them change things. They can change the things. All they need is the coach and somebody who guides them on the path. And I think, giving a person in therapy that impression, believing in them like that, and again, creating that hope because they can do it, is very helpful. And I think it really helps to decrease burnout as well.
Mm-hmm. So as you're speaking, a couple of things come to mind. The first of which is, can you take a deep dive and share with us a particular experience when that happened and what that looked like for you? I mean, how did that impact the client you were working with? I'm curious about that. All right. I don't know if you follow me on Instagram or not, but when I do interviews, I usually do 2 interviews a week. I conduct 2 interviews a week. And usually I get so excited. I get so pumped up after these interviews because I get to talk to incredible people. And what I usually do is I go on Instagram and I talk about it. I want to share that excitement. Usually there's about a 2-month turnaround on my podcast, which means that they don't go live for a couple of months. And I have a problem with that because I want to share it. I get so excited about these things. So what I've done is I've created a membership called Trauma Therapist Plus, and it allows people for $5 a month to access these episodes about 2 months before they get published to the public. And you can also listen ad-free, which is really cool. So if you're interested in that, if you're interested in listening to episodes before they get released to the general public and also listening ad-free, check it out. You can access it by going to Apple Podcasts and just clicking on any of the episodes that has a plus, Plus, before it. It's exciting. I'm excited about it. And you'll also help support the podcast. Thank you so much for being a listener. I really appreciate it. Take care.
Yeah, I had one client. She had PTSD. She had a severe eating disorder. She was very dysregulated. She often threatened parasuicidal behavior. And I was quite tense. I was very early on in my training. And, I remember I was out at a birthday party and I was very worried about her. And, I tried calling her a couple times and, she didn't answer the phone. And I think, she was home, but, didn't really want to answer the phone, which she admitted to me later. And I just got very tense, and my whole evening was taken up by thinking about this client. And, as you get more experience and as I think you realize how many strengths these clients have and that they can get through it, I think if I had been more experienced, I could have sat back more and thought, she's going through a rough time. We had an appointment today. I'm going to see her again this week. She's going to be okay. Having that faith and having, the realization that, she's been through so much, she can get through it. Yeah.
The other thing that comes to mind, Ruth, is that, sitting back, to use the word you used and to allow the client's strengths to come to the fore, if you will.
Yeah.
Why is that challenging for therapists? And why was that challenging for you?
Because I think we're trained that we have to do things, right? We have to, if something happens, it's really weird. I think especially with trauma symptoms, for example, if a client cuts herself or himself, therapists feel that it's their fault, right? For some reason, right? And, if a schizophrenic patient has hallucinations, we would never feel it's our fault, right? But so often when our clients self-harm or, they're more suicidal, therapists tend to think, it's their fault.
Mm-hmm.
And I think we need to move away from that. It's a symptom, right?
Mm-hmm.
It's a symptom of the illness. We're there to help the client overcome these symptoms. We're here to help them to regulate better. And we're really here to help, and I often use this analogy in treatment, to watch the butterfly unfold, right? That when we start, it's almost like we're working with a larva, right? And within that larva is a beautiful butterfly that needs space, that needs time to unfold. So I think that's, one approach that's been very helpful for me.
So before we get to the your advice for clinicians, I just want to pull out here my take home here in this particular topic is, realize and recognize that we're not here to fix our clients, and we're here to coach our clients. What's the take home for our listeners here that you feel?
Well, I think if you're trying to fix your clients, you're actually implying that they're incompetent, right? If we help them to fix themselves, we're telling them, you're competent, you've got great strengths, and we're here to help you to fix yourself. Does that make sense?
It does. And I just love this sense of empowering, it empowers our clients.
Yeah. Yeah.
Which is exactly what they're coming into our office because they feel they don't have that power.
Exactly.
So,
and I think this is what prevents burnout as well. I really believe that. If you can take that stance, that coach stance, and empower the client and, help them to fix themselves, I think that is the key to prevent burnout and secondary traumatization.
Do you see, we're going on this topic, but it's fascinating to me, but do you feel that it's something, for me, I've spoken with a number of people on this podcast, and this topic comes up a lot, and it comes up from seasoned clinicians like yourself who've had to learn that the hard way.
Yeah.
But okay, let's move on here, and we get to really one of my favorite questions, Ruth, which is your why. What keeps you going? What is your why with this work?
Well, I think, I've been I've had the honor really to have been witness to a number of these rebirths of the sense of self. And I think it's an amazing thing. And I think that's what keeps me going.
Very, very powerful. I love that. So let's break it down now. A lot of people listening to this podcast are clinicians just beginning to get into the field of trauma. Some are more practiced, yet really don't believe that they've been working with trauma clients. But what would you say, what would you advise individuals just getting into this field?
Yeah, I think I would probably advise a few things. One is you really need a good treatment frame and set out your expectations right at the beginning. So, for example, how often are you going to see the client, discuss it with them? How long is the treatment going to take place for? And how are the two of you going to manage crisis situations? So both you and the client have this treatment frame in your mind. And I think it's really important to stick to that because, traumatized clients' lives were very, very unpredictable. And so this is something you don't want to recreate in the therapy. So you really want to set up, a treatment frame that's very predictable, which is very different from what they've had. Then I think creating hope right at the beginning is extremely important. And, empowering the client, like we talked about earlier, those are very important things. And then I think supervision is very important, right? And this is not just for early therapists, but this is also for seasoned therapists. Difficult things arise, right? These are difficult clients to treat. They suffer a lot. We're impacted by that. And so to have an experienced person for supervision, I think is really important, where you can run by some of your difficulties, discuss different management strategies. If you're working on a team, have weekly rounds where you can discuss ideas with each other. I think those are really important things.
Great. Okay, so 1, 2, and 3. Begin by setting out a treatment frame. Set it out. Create something that's really predictable. Discuss how crises are going to be handled. So right from the get-go, you're creating a sense of structure, which oftentimes, as we know, a lot of our clients don't have. Number 2, create hope. We've talked about that. Very powerful. And finally, consultation, supervision, which is important and crucial for new therapists and seasoned clinicians alike. Awesome.
Yeah.
All right. So before we get to your book, well, let's jump in and talk about your book, Healing the Traumatized Self, Consciousness, Neuroscience, and Treatment. Before we talk about, what it is, why did you write this book? What inspired you to write it?
I think one thing Paul Fruin and I had been interested for a long period of time is really how dissociation affects mind, brain, and body. And as we know, dissociation is a strategy many traumatized people use during the trauma to help them to survive, right? Whether that's in terms of detaching themselves from intense emotional states, or whether that's becoming so fragmented in order to survive. And yet, when we were faced with these difficulties in the aftermath of trauma, we know how it can really prevent good quality of life. And so it's something we've been really interested both from a clinical perspective, but also from a neurobiological perspective to really figure out what's going on in the brain when people have these responses. And so this is what we wanted to focus on in the book, and we really wanted to bring together clinical work and research. So we interviewed a lot of patients to really get their own experience. And then we looked at a lot of neurobiological research, and we really wanted to marry the two and come up with a model that helps us to distinguish dissociative symptoms in 4 dimensions of consciousness: time, body, thought, and emotion, from non-dissociative symptoms. So that's sort of the focus of the book in a nutshell.
Nice. So one of the words that I want to, pull out here is you use the word strategy.
Yeah.
Talk about that a little bit.
Strategy in terms of what do you mean, Guy?
Well, you said dissociation is a strategy that sometimes clients use.
Yeah.
And that to me I love that term. Talk about what you meant by that.
Yeah, and strategy sort of implies that you have control over it, right? And often dissociation, you don't have control over it. It just happens. So I'm not sure whether it's actually the right word.
Okay.
But for example, we have an example in the book of a client who was repeatedly gang raped during her adolescence. And she describes how she was in the tree and how she was watching her body being raped over and over again. And she describes how she couldn't feel being raped because she was out of her body in the tree. And, she also describes how she was able to have empathy for that shell, really, that was being raped on the ground. So I think it's just amazing what the mind can do to help us adapt to trauma. And yet, of course, when we're trying to live a normal life and we're so detached from emotions because of out-of-body experiences, then we can't experience the full range of emotions, right? We feel dead, we feel numbed. So how can we help a person reconnect with those emotional states where the disconnection was helpful at the time of the trauma, but now is no longer helpful? Mm-hmm. So that's, I think, what I meant by strategy. It can be adaptive and a productive strategy at the time of the trauma, and yet when it's occurring in the aftermath of the trauma, it's no longer useful, and it really prevents us from functioning fully in life.
So you said you, in the book, kind of break down dissociation into 4 kind of components. Can you talk just briefly about what those are? Share with our listeners what those are.
Yeah, there are 4 dimensions of consciousness that have been proposed by Zahavi and Thompson originally, and they concern the dimension of time. So as we know, our experience of time can be very affected by trauma, right? For example, when we have flashbacks, individuals often feel like they're back at the scene of the trauma, right? They lose touch with the present time and they feel like they're reliving the trauma. And so that would be an example where the dimension of time would be really affected. In terms of dimension of thought, usually the way we experience life is almost akin sort of to a story, right? Stories have a beginning, middle, and an end, and they're often told in the first person perspective normally, right? Mm-hmm. But when we think about our traumatized clients already, we can see that's not often the case, right? So when we hear a trauma story, it usually doesn't have a beginning, middle, and an end, but it's very fragmented, right? And in severe cases, the first person perspective also changes and people can start to hear voices. So you're no longer the sole narrator of your experience. So rather than, having a thought, for example, I am bad, you now have a voice saying you're bad. And so your narrative now becomes shared among several narrators that can be in the form of voices. And I think that can be related to sometimes experiencing a fragmented sense of self. And then the dimension of body, an example would be these out-of-body experiences that we have just talked about, that would be an alteration in consciousness of body. And then emotion, as we know, is very much affected by trauma. People can have too much emotion, but they can also have too little emotion where they're really numbed out, or they're very dissociated from their emotion, that the emotion also almost feels like it's experienced by a perceived other, which would be a real alteration in consciousness as well.
Okay, so we've got time, we've got thought, body, emotion, all impacted here. Ruth, the book is Healing the Traumatized Self by yourself with also Paul Fruin.
Yes.
Share with our listeners a book that's inspired you, and that can obviously be trauma-related or not.
I think the 2 trauma-related books that have really inspired me are Trauma and Recovery by Judy Herman, as well as The Body Keeps the Score by Bessel van der Kolk. Okay.
Trauma and Recovery, of course, comes up again, and Bessel van der Kolk's most recent book, The Body Keeps the Score. What is the best way for people to get in touch with you, Ruth?
I think through email, which is ruth.lanius@lhsc.on.ca.
Okay, ruth.lanius@lhsc.on.ca. Got it.
Yes.
All right, so we'll have links to all this up at the show notes page, including the link to your book. And Ruth, I really appreciate you taking the time to do this. It's been a delight speaking with you. I just love your ability to communicate the work you do in just accessible terms to our listeners. But it's inspiring too to hear the passion you have and the hope you have for the clients.
Well, thanks so much for your time, Guy.
All right. We will
really appreciate it.
You are welcome. Take care.
Yeah, take care.
Bye-bye.
Bye-bye.